Thanks everybody for coming. This is going to be either an exciting or a disastrous session because we're going to start talking about what we really think about now. So, but this is going to be great, and I gave a personal briefing to the governor's chief of staff and 3 or 4 of his people about 3 weeks ago. And one of the things that I said to him, I said, this commission is really loaded with people who are not only have experience in this field of different types, but they are really committed, they're really smart, and they're really practical about how they get things done. And I said, I think we're going to really come up with a good product. And he said, well, how's your attendance at the meetings been? And I said, well, I think it's pretty good. As far as I can remember, we just about have 100% attendance every time we have a commission meeting. And so one of the ladies who was there with him works for him in the press area. And she said, yes, they're always there. It's an amazing group of people. So we're going to go through some presentations today and have some discussions about our thoughts about things. I guess the first thing to do is to establish a quorum. So Shane, have you found, do we have a quorum here?
I think we have a couple folks missing, so I'll just do a quick roll call. Dr. Box?
Here.
Dr. Monroe?
Here.
Senator Kenley?
Hi.
Dr. Maxey?
Here.
Mr. Ellison?
Here.
Mr. Tabor?
Here.
Dr. Veal?
Here.
Ms. Irwin?
Here.
Ms. Waldron?
Here.
Dr. Halverson?
Here.
Dr. Kane? Dr. Welsh?
Present.
Commissioner Bardsley?
Present.
Mayor Courtney?
Here.
Commissioner Dawes?
Present.
And Congresswoman Brooks is unavailable.
Thank you, Shane. Dr. Box, you have any opening comments before we start through these agendas?
Thanks, Senator Kenley. I just want to thank everybody for continuously coming here. I also want to thank Claire Fitty and Green, who's here. You know, the Fairbanks Foundation gave us money to get this commission started up and to hire a consulting agency. So they're really kind of the start of this. And I really want to genuinely say thank you for that. We appreciate your support and appreciate you being here. I think that we have really listened to the commission, and we're going to listen again for the next 2 to 3 sessions. We have really listened to the public in our public health listening tour that we've done, on the online comments and other things that have come in. We continue to present those. And I think that's really, really important. So we're not creating this document in a vacuum, which I love. I think there's been a lot of really good input. The most important thing about today is what you see, and what we're presenting is merely a starting point. We figured coming in here with a totally blank slate would be a next to impossible feat to try to get through 3 of these specific areas. So this is a starting point for people to launch off. You need to feel comfortable and safe to say what needs to be added, what needs to be subtracted. We need to have a very respectful but vigorous discussion about that. And if it really seems like people are divided, we might decide to take a vote on certain things today, but most of it we may wait until we get the whole document together here at the end. I think we've got a long way to go before we finalize this report. So don't feel like today is like the end all be all and things cannot be adjusted or changed. If there's a particular wording or problem you are struggling with, feel free to take it home, rework it, send it back to Shane or I. We will re-look at it, kind of send it out to the commission and get other input. Our goal, as you know, is to continue to ensure that every Hoosier in the state of Indiana has an equal and equitable access to public health services around our state. So thank you from the bottom of my heart for your time.
Thank you, Dr. Box. Dr. Monroe, you get to view us from afar and then you come and visit with us. What words of wisdom do you have for us today?
Well, hello, everyone. I do want to add my thanks to the Fairbanks Foundation. Really terrific to see philanthropy step in and help. Well, great to see everyone. What month are we in now? This is April. I want to give my commendation to everyone for the attendance. I think that's terrific to hear that. So I think the recommendations that we're going to be discussing today really represent the critical aspects of public health and how we are going to reshape the work being done in Indiana. So this is a really important meeting. And so if we take governance and services, those touch on the most foundational aspects of how we operate daily and interact with Hoosiers. Data and information will enable that transformation going forward. And then underpinning all of that is, of course, workforce. We can't deliver any of these services or modernize without a workforce that's skilled and passionate. I do want to call out the Public Health Workforce Interest and Needs Survey from 2021 found that nearly half of the respondents had some form of post-traumatic stress disorder in the public health workforce. So these symptoms, and nearly a third reported bullying or harassment. So as we think about our workforce, we really need, to discuss that aspect as well today. And we need to address that to ensure that we have a strong workforce for the future and one that Hoosiers understand are there really to improve their health and they're in their corner. I think that's the thing. Public health is in the corner for all Hoosiers. And as Dr. Box said, the idea is to have delivery of services that represent everyone and are equally distributed across the states.
Thank you, Dr. Monroe. This time, could I have a motion to approve the minutes that we
Motion to accept.
Second.
moved and seconded? We accept the minutes as presented. All in favor, say aye.
Aye.
Thank you. Shane, I think you're going to bring us up to date on the public comment and input summary and some of the listening tour activities. So why don't you go ahead?
Sure. And before I do that, I'll just note a couple of you have reached out about the live stream. Unfortunately, we are having a couple tech issues, but we're recording the session, so that'll still get posted for others to view later, just not in real time quite yet. So apologies about that. Regarding the public comments, for the online form, we did receive 105 comments between March 10th and April 13th. 75 of those were related to opposition of expansion of public health authority and mandates, really emphasizing the patient-provider relationship, as well as asking public health to continue focusing on the safety aspect and more on the inspection side of things, as opposed to things related to the pandemic. And they also made note about concerns with data and information sharing, especially through electronic medical records. We had a variety of comments relative to various concerns, ranging from wanting the commission to focus on obesity, tobacco use, food insecurity, and determinants of health, as well as specific concerns about legislation. All of those are synopsized more discreetly in your packets. Multiple folks mentioned concerns about public health funding and the need for increased funding. We also had some notes about workforce, particularly at the state and local levels relative to pay and ability to recruit trained individuals. So making sure that there was appropriate supports at all levels relative to that. And then I did want to call attention that approximately 3 comments focused on health equity and focusing on vulnerable populations and making sure that we had that at the center of our work in general. Shifting gears to the listening tour summary, as you recall, we conducted 7 listening tours around the state in a variety of areas, and quite frankly, some non-traditional spots than what you might expect. We had really good turnout. The transcripts from those are pretty voluminous because we allowed folks to speak for 3 minutes. And so we are still transcribing and processing some of those. So our partners at HMA are helping with that. We have the first 3 completed for Jasper, Newcastle, and Huntington. And for those of you who are looking at that chronologically, yes, Huntington was after Seymour, but Seymour will be caught up in the next batch. But overall, we had representation from 15 different counties. And I think you'll find with the next batch of these comments, similar spread. We were pretty pleased with the turnout. As these continued on, we found that more and more folks were participating in the process. Oftentimes the rooms were packed, but we didn't find that everyone wanted to comment. So I don't know if it was a situation where folks felt like their issues had been raised or brought earlier, or they really just kind of wanted to see and learn. We did adapt that process partway through by providing more of an expanded presentation about public health and the purpose and why we were really there, based on some feedback that we had after a couple of the sessions. And I think it was an opportunity for us to leverage what we've heard here, which is there's not always a common understanding or foundation of what public health does. And so we were able to kind of evangelize in that way and help folks see that. And I think that also tempered maybe some of the conversation. I won't go through each of these 40 comments that were synopsized here because they are so varied and unique that it would be pretty difficult to do in lieu of the time that we have, but I would encourage you to take a look at that. And this summary, as well as the public comment summary, is posted on our website as well. So we'll have that transparency additionally.
Thank you, Shane. Any specific questions for Shane? I think this has been a good exercise for us, and had an opportunity to be on some of the listening tour events. And I think by trying to reach out in different ways, we're getting a good sense of how people feel about these things. And fortunately, most of the comments and everything, even the ones of concern or disagreement, have been pretty civil in nature. So I think it's been a good beneficial exercise. And Dr. Box and I have continued to do a few Zoom meetings with different groups. So we're trying to knock off 6.5 million people within, just having Zoom meetings.
30 to 60 people at a time.
That's right. We're going to go through, and we've tried to allocate about 55 minutes to each of these areas. We have 3 areas today. Hannah's going to make a presentation on the workforce recommendations based on our past information. And then Pam is going to give us some information on governance, services, infrastructure recommendations. And Lindsay is going to bring us up to speed on data and information. Each of them are going to present recommendations for you to sort of look at, work from, debate, discuss, enlarge. If you have other thoughts that you think needed to be added into these areas, this is the time to present them. Let's let them make their presentation, and then we can start the dialogue and the discussion. And obviously, we want to be productive and don't have anybody that has too much to say or dominate a particular subject, Dr. Halverson. So even though you know everything. Yeah. Just give us the bullet points. So with that, I'm going to ask Hannah to make a presentation for us. Workforce recommendations.
Thank you so much, Senator Kenley, Dr. Monroe, and fellow commissioners. I'm delighted to be able to speak and present some proposed recommendations for workforce to the commission today. I'd like to begin with some thoughts before we roll into the recommendations. Promoting, protecting, supporting, and maintaining the health of our citizens and communities requires a workforce of sufficient skills and size, equitably distributed across our state, representative of our people. As my colleague Courtney Medlock shared with the commission back in October when I missed the meeting, I'm very sorry if I'm the one person that's missed. The workforce is large. It includes an array of professionals and roles working both in public health and healthcare sector spaces. While these sectors and their workforces are frequently differentiated in discussions, the health of our population is their ultimate shared goal. And we all know that healthcare professionals contribute to public health, and public health professionals are working in and contribute to healthcare. Workforce issues have been raised in many of our commission meetings, most of our discussions. Workforce has been raised in some way or another, and in many of the listening sessions. Shortages have been the standing theme in most discussions. While some of Indiana's workforce shortages are more well documented than others, we know that they range from overall shortages of personnel within our state or within certain communities or serving certain populations to shortages within specific sectors, specific settings, or specific roles. We've even discussed shortages of specific skills that are needed in certain jobs. Important conversations such as access to services, quality of care, or quality of services delivered are extremely challenging and perhaps unachievable unless we have a workforce. So the million-dollar questions on the table for the commission are, what factors are contributing to our health workforce shortages, and how can we address them? These are really big questions and would require extremely complex answers. Just a few of the cited factors: training capacity is insufficient. Competition from other sectors is taking people out of our health sectors. Wages and classification systems for our workers. Lack of mobility or career pathway development, and regulatory challenges. And these are just a few of the themes that have been discussed. We as a commission will not be able to solve all or even many of these issues, but we may be able to support the development of capacity which ensures Indiana is poised with a coordinated approach to identify and address challenges for our future. The overarching vision that I would put before you: conversations about the health workforce no longer dominated by shortage. So I'd like to share with you perhaps two overall goals that I can help frame up the recommendations that we're going to go through, and they're brief. The first is ensuring that Indiana has sufficient information on our health workforce. And when I say health workforce, I mean both public health and healthcare collectively, to identify our shortages, target our needs, and to support workforce planning. The second overall goal: enhance our training, recruitment, and retention to ensure workforce capacity and skills are sufficient to support Hoosier Health. The recommendations that have been drafted for your consideration, and I will be going through these one at a time with some proposed action items that we'll look forward to discussing with you all. First is coordinating current initiatives and providing a framework for the development of a state health workforce plan. The second is ensuring representation of public health in health workforce and workforce initiatives. Enhance workforce reporting to understand public health and clinical workforce needs and the status of our talent pipeline. And then finally, expand health workforce incentives and programming to support personnel recruitment and retention into our areas of need. I'll go through the first one with you and just discuss some proposed action steps. Benjamin Franklin famously said, and I'm sure all of you are aware, failing to plan is planning to fail. Now, I'd like to say there are a lot of excellent planning initiatives that are going on in the workforce, in the health workforce. These conversations, while high quality and actionable, are not collective and not coordinated. The possible action steps to coordinate current initiatives and provide a framework for development of a state health workforce plan, I would propose, has to begin with several action steps. The first of which is identifying an entity to oversee and own coordination and planning for the state of Indiana. The second is identifying existing programming initiatives involved in the health workforce. I mentioned we have a lot of excellent initiatives. We need an inventory of those so that we can begin to create a framework for synergies and coordination across all of them. Finally, and as a last step, but a beginning step perhaps towards moving our workforce discussions forward, we need to develop a comprehensive health workforce assessment and collective plan for our state that is actionable and implementable, and that can be evaluated and refined moving forward. Draft recommendation number 2, ensure representation of public health on health workforce, and I would say workforce initiatives within our state. The 2 potential action items, the first of which is to have the Department of Health represented on the Indiana Graduate Medical Education Board. This board is an excellent body that is doing excellent work within our state to expand our graduate medical education residency programs here across the state, enhancing that with the public health perspective that has knowledge of our population health needs, may help to increase and inform GME initiatives moving forward and assure alignment between our GME activities and our public health priorities and initiatives. The second potential action and opportunity is coordination or enhanced coordination with the governor's workforce cabinet, as it is looking at and working on workforce issues widely for our state. There are opportunities for health representation, or at least healthcare and public health to be a part of or coordinated with discussions. Draft recommendation number 3, enhance workforce reporting to understand public health and clinical workforce needs and the status of our pipeline. For those of you that are aware of work that's going on in Indiana, we're fortunate to have fairly high resolution data on some of our licensed healthcare professionals, specifically some that are licensed through boards at the Professional Licensing Agency. We are very fortunate that we have data collection initiatives to be able to quantify our workforce in some spaces. Unfortunately, this is not the case for our entire health workforce. In public health, we have not very strong or robust data collection and workforce reporting mechanisms. One of the potential actions that I would put forward for consideration is development of a standardized workforce reporting metric or system for state and local health departments to ensure that Indiana can keep its finger on the pulse of our public health workforce. Such data are critical to understand our current state and to plan for what we need and to prepare projections. The second possible action item is to share this aggregated information back to the local health departments to support their analyses, comparisons, and process improvement initiatives. The third action item is quantify and describe Indiana's health workforce pipeline and retention by degree and occupation using existing data sources. So in Indiana, we do actually have quite a bit of data on our pipeline, but it has never been assessed in a coordinated fashion for our health workforce. An assessment such as this would provide us with an overview of what that pipeline looks like and would help us understand where we have opportunities to modify or expand our pipeline to better meet the needs of our citizens and our systems. Finally, identifying additional health-related occupations, especially those that are regulated, where workforce data could be collected and valuable, and implementing data collection strategies. I referenced that we already have robust data, for example, on our physicians and registered nurses. Those data are collected at the time of their license renewal as a standardized set of questions that are seamlessly embedded into that renewal process. Those data provide us with critical information, not just to be able to not just count the number of licensed people we have in the state, how many are actually actively practicing within our state and within specific communities. Some of the professions that could be considered for additional data collection are EMS professionals and professionals regulated by the Department of Health, such as certified nurse aides, home health aides, and others, especially those where we know we have grave workforce shortages currently. The fourth and final draft recommendation for your consideration today is expanding health workforce incentives and programming to support personnel recruitment and retention into areas of need. Some possible actions for consideration by the Commission: for the Department of Health and Social and Services Administration to collaborate with other agencies and coordinate on workforce incentive strategies, especially those that are typically administered by states and leveraged to support strategic workforce recruitment into areas of need. For example, loan repayment programs. The second area is to promote experiential learning opportunities in public health through internships and fellowships. And I would like to clarify that these should be very applied and very targeted to the specific needs we have here within our state. Finally, create cross-training opportunities or expand those opportunities in public health for students within our clinical health sciences programs. We know, as I said in my level setting remarks, healthcare professionals are a part of our public health system. We want to ensure that they are prepared with the appropriate skills to champion public health, whether they're in clinical practice or whether they stand as a local health officer. I will look forward to taking questions. I am going to return to my seat during discussion.
Okay. Who wants to kick the ball off with any comments or suggestions? Yes, David, and then Virginia.
First, thank you very much. I think we could spend the whole 4 hours on just your recommendations. Maybe I'll go from last to first, if I could. Really like the incentive program. I think that can work. I think promoting the learning into other areas, and something that we can probably look to is working with other groups, whether it's Kim's group or that State Medical Association, the Hospital Association, and offer bits of public health training information, Dr. Howerson, and to people in medical school, undergrad, and residency, so that they can learn a little bit more about the opportunities. It can also, if the group's interested, I can connect us with the folks in the U.S. Public Health Service who have been really struggling to try to get their opportunities to other medical professionals, like through the AMA. And I've been working with them to try to promote that. Love the cross training. Love the cross training. I like your idea about finding out the status of folks. We've got a lot of retired part-time professionals, and I think keeping tabs on that is important. In addition to the areas that you listed, like EMS, of things to get a hold of, extended care facilities, home health, and hospice, psychologists. But I'm thinking also making sure that we track the workers in the school nursing programs, because we need to see what they have, what the shortfalls are. And I really like the aggregate information, so that when we're talking to folks in undergrad and high school levels, talking to the counselors, if we knew what the plans were for the local health departments for replacement or expansion of their services, and then get that to the school counselors, like, if you've been thinking about this area of public health, there's going to be an expected need in these following areas. If you have, and that can also be tied to externships, so that people can walk a few miles in the shoes of the folks in either acute care. They already do that with acute care, but in public health. And I think as far as the comprehensive workforce assessment, I would suggest we think about kind of a 3-tiered approach. One, the bare bones basics. We can't go below this and keep the engine running. The kind of a moderate, like, this is okay, you got the bare bones going, let's add a few things to help the folks in the community. I can kind of say that's the approach I had taken with one of the counties that I've been helping with. And then the top tier. So, okay, you got the basics in place. You've added some things. What would you really like to do? And I think we need to have people thinking not status quo. We need to be thinking about what are the needs? How do we reach those needs? And let's let's go beyond expectations. It's like dealing with a student, you don't want them just to pass their courses. You want them to do well. And then when they're doing well, you want to prod them to excel. It's like, you were C's, now you're working on B's. I bet you can get a couple of these subjects to A's. I'm pretty sure. Well, we can do the same thing with our health departments. Recruiting and retention is going to be key. I've been living that firsthand. And I'm happy to report both my counties are full staff now. But it is a challenge.
Yeah.
And it's how do you get the word out to folks? And if there was a central repository, and I know there was one other thing you mentioned about what's out there already. So often, whether it's with workforce related issues or resources at the state or local level, a lot of times people, I wish we just had X. It's well, we do. Well, how do you find it? Well, here's how you find it. So just getting that information in an easy to access location so that people know like, oh, that is available. I've got a student who's interested in more. Let's get them connected with that information so they can see, there's going to be an estimated shortage of public health nurses. There already is, but I mean, the projection of the need. And if we had a central location for that, I think that would get people thinking, get parents thinking. It's like, Susie or Johnny, you've been talking over the time you wanted to do, but you didn't really want to do that healthcare in the operating room. You didn't like that experience, but there's other areas of medicine. But I'm really excited, as you can tell, with the proposals. But I think this is I think a really good start.
Thank you so much.
Dr. Kane?
Well, thank you, Dr. Maxia. I've been a fan since she was a student. Okay, so just a remarkable talent here. One of the things I was trying to figure out how we could add as a recommendation, you can have a workforce and you can have a pipeline, but if you're going into positions that are so underpaid, I don't care what kind of pipeline you have and what kind of programs you have, incentives for them to do the training. If the position being paid is so low, you will never recruit people. So that's my first point. So I don't know if there's some kind of way we can be able to say for this particular public health position, these are the salary ranges you should look at for someone to have a flavor or look at that. And I'll give you my example. I'm down 15 housing inspectors and I'm down about 15 nursing positions. And when I reviewed that, I was shocked to find out that my minimum wage for housing inspectors was $31,000 and something. Hamilton County is like at 56,000. And the next of the surrounding counties, at least the next highest salary was like at 38,000. So I think we do have to look and get a flavor of, so what should be, I may not make market, but how do I get kind of close to market so that I'm competitive? So that's my first point. Second point real quickly is I get thousands of calls for students to do internships at our health department. And I would love to accommodate them, but they also want paid internships. And I have to say, honestly, I'm happy to let you come and do an internship, but I don't have the financial resources to pay you for those internships. So is there some kind of state program or something like that that would allow them to have a paid internship, a certain number? So I don't have to turn everyone away who wants a paid internship. So some kind of way looking at that. And I just love I'm with Dave down there. I love that cross training. Opportunities in public health for the students in clinical health programs. For example, people who are interested in health policy or the legal activities related to this COVID. Wonderful opportunities for them to learn about how we generate health policy. What do we think about in terms of policies for the community? What are some of those legal things that we have to look at? We have wonderful opportunities experience for that. Epidemiology, how do you identify if you got all these cases, where do you concentrate your efforts on? So how do you make that decision? What kind of information do you have to have in order to make where you want to prioritize your resources? Planning and logistics. I think that's something that's wonderful, but I think the most important point is, how do you do community engagement with who you need to reach, who you need to motivate and make changes happen? So I think there's some wonderful cross-training opportunities, can be short-term, longer months if you want to, that I think a lot of our students would love. And then don't forget about physician assistants along with the nurses, okay?
So when you talk about internships, and you can, if you want, you can think on this and maybe send us an answer later. Do you see that as a paid internship? Do you see that being organized by the State Department and then funnel it out to the local health departments as being the best way to do that? Or-
I think there needs to be a central body. So
Okay.
whether it's the State Department of Health,
Right.
but somebody centralized for the state.
Yeah.
And then, so a student can call me up and I
Okay.
can say, hey, we will try to apply through this central body in order to pay for your internship this summer.
Right. Okay. That's what I was trying to figure out. Yes, Commissioner.
I ditto Dr. Kane and Dr. Welsh comments, and thank you, Dr. Maxey, as well. But to kind of piggyback on kind of the whole area of training and so forth, and I know we're on kind of draft recommendation 4, but tying into that on recommendation 2, where it talks about the Indiana Graduate Medical Education Board and having someone from the State Board of Health on that. I'm thinking there of the residency programs for physicians, and I don't even know this, if there is a residency in public health or not, and maybe that needs to be looked into. And then how is that paid for as well? So that goes back to kind of that area of funding, which I think it would be great to promote internships and fellowships in public health, not just residency program for a physician, but in other areas in public health, internships and fellowships and so forth. And I agree totally with Dr. Kane, and that's what I wrote down in my notes was, how are those going to be funded? And where does that come from? And so forth. So I think, because most, I'll say kids, most kids today, want internships, want fellowships, but they also want to be paid. And so that's, those are some of my comments. I guess I like the idea of working together with other organizations, Indiana Hospital Association, Indiana State Medical, involve those organizations and others in that whole area as well. I think it'll be critical, and I think it would be helpful.
Yes, Hannah, go ahead.
Thank you so much for that. I do want to address some of the issues that have been raised, specifically about funding, because that is an elephant in every conversation, right? There have been opportunities since we have been meeting at the federal level that we have not been in the position to go after that could have provided funding to our state to support some of these activities. Identifying ownership and having infrastructure and capacity to own these types of conversations and the pursuit of funding opportunities will be absolutely critical. So if there's no one to say, okay, we need this person, this group, this entity to champion it, it'll be a good idea, but it will not go anywhere. And we will not be able to secure funding or implement programs. So I just wanted to bring that up because I agree with you all. And I have a daughter that just graduated high school and she is doing an internship as a dental assistant, but it's paid. And even our high school students that are doing internships now during their senior years are looking for paid internships. And so I think we have to be very realistic and know that that's a reality that students are to somewhat expecting.
Would you send Shane or somebody a couple of references to federal programs that are out there that we're not taking advantage of now, so we have a better feel for that? Dr. Monroe?
Yeah, I wanted to make a couple of comments. So there's a preventive medicine residency
Right.
program, but I have no idea here in the state of Indiana.
Zero.
Okay, there you have it. So there's an opportunity.
But does that involve what I would call kind of the broad area of public?
Yes,
Yeah.
yes, that's what they
Oh, it
do.
does.
Right.
Okay,
Actually, American Board of Preventive Medicine.
okay.
And
Yep.
it's an established residency.
That's right. And then I wanted to comment on paid internships. So we, at the CDC Foundation, when I first arrived, I said, so where are the interns? And the answer was, well, we don't do interns. It was too much trouble. And I said, wrong answer. And then we started establishing an internship program. And it became very clear that we were going to have to pay. And so our current rate right now is $1,500 a month for master level students that do internships. And we have them lined out through the door and they are fantastic. The contribution of your interns coming in are just over the top. So you talk about a value add for $1,500 a month at the master level. So,
We need interns for the college level because we want them to get into public health.
yeah, exactly. So you can go from there, coming out of high school.
Yeah, it sounds like we might be able to make some very specific recommendations and maybe enlarge on that a little bit. Hannah, if you wouldn't mind kind of fleshing that out
Yeah,
for us.
if I might, I would just want to add that in our experience at IMHC, where we have both graduate and undergraduate interns, primarily students of color, that our experience is that paid internships are critical because these students, in order to be in a pipeline, really do need the income as well as the experience that we provide. So for purposes of having a workforce diversity, paid internships is especially important to students of
Good.
color.
And that increases accessibility and equitability of access to internships opportunities. Thank you for saying that.
Great. Kara?
Does that, and I don't know the answer to this, but are there educational programs that restrict paid intern and externship? And I just wonder, university to university, I know we take some interns that they cannot accept a stipend because of requirements of the university or at whatever track or division or discipline they're going down. So
I
I don't
know-
know if that's restrictive in any way.
I know Purdue doesn't because I get a lot of calls from them. IU doesn't, so I don't know about any other.
So maybe state schools, but
Possibly. So I can't speak to specific programs and what the requirements are. I have heard some students say, I need to do a project and I am not allowed to be paid for it. But I can't speak to the formal, requirements within program. I can't speak to that most students that have come to at least the Bowen Center at IU are searching for paid internship opportunities.
Yeah.
So,
And I think we're not talking clinical rotation.
Yes.
We're talking intern extra.
Yes.
I think that's maybe an important note when
Yes.
you are considering public health versus healthcare or both.
mhm.
Yes, Mindy and then Dr. Wells.
Great presentation, and I'm on for all of the recommendations that you have. Just a couple of tweaks. I was wondering if we could somehow get in the language would be, and I can send these in writing if it's helpful. The internship thing is a really big thing for us, and most of us don't know how to navigate. Like, there's several counties, we were on a call yesterday about it, where we have programs set with our schools, and they sometimes will pay the internship for you. And so we've aligned ourselves with a couple of them that do that, so I don't have to navigate that part. But others don't really know how to tap that. So if we develop something, if there's a way to also say how you easily utilize it, and if there can be programs for placement and vetting these people, and it just basically be, we can post internship projects we have, you help assign wherever group it is, and help get them there. And we all need them. So we talk about this a lot. We just don't really always know how to find them or who can do them. It's a very large process for us. Other thing I thought tied into that would be helpful is these positions that we all have open now, we're all left to navigate finding people for them. And most of the time, we can't spend money to advertise or to post. So if we could come up with the monster.com of public health, of the local health departments and the state health department positions, because all that happens right now is every day we all send emails to each other, and the state sends them to us, like you have positions, we send it, say, hey, can you get it out? So it'd be nice, a central repository for the actual openings, and it's a double win for the pipeline thing. My other comment with Dr. Kane, right with her, is this salary range guidance for specific positions for counties that make their own decisions, because all of them, all cities and counties, they all do it. And the ranges are so far off right now. So a guidance, and then they'll always say, well, who's paying what in what other county? Or they'll say, what is the going market rate? Well, you're left to figure that on yourself. There aren't formed HR divisions generally in public health or in some counties. So it would be helpful if we had that, if it could all be tied together where we can tap that stuff and grab it and take to certain meetings where our elected officials are making quick decisions about that. So those things would be very helpful resources to be in place for us. Otherwise, all awesome, and thank you.
I just want to note we're at the halfway mark for this work stream.
Okay,
Mhm.
yeah, Kim.
Was somebody?
Oh, yeah, sorry, Dave.
So I've been checking, when you check AAMC, they have pathways to public health training. The most typical path is a residency and pick your specialty. Preventive health, as Dr. Halverson mentioned, is a good one, but a lot of folks will then get their master's in public health along with the residency training in another area. I've got calls out to several groups. If I hear back, I will pass that on to the group. The cross training, one other thing I thought of as the other esteemed colleagues were talking, I'm always bothering Mr. Tabor, my colleague. Cross training with the hospital and clinic personnel is essential. And you can also cross train with first responders. Think emergency planning. Think of the hospital. They all have ID nurses. They all have ID, depending on their size, infectious disease departments. And that tied to your health departments is important. Also can think of community health problems, smoking, diabetes, obesity. Those are problems that are trying to be tackled by folks in clinics and hospitals across the state. And cross-training with our colleagues in the acute care, as was mentioned in your presentation, I think would be key so that we can tie our public health to our acute care health and have a better outcome.
Yeah, Kim.
Sure. One comment, one question. Also on the internships, that was one of the gaps we identified early on, or as we started to work more with students, was the coordination piece, like just connecting students with sites. I will say there's a capacity building issue with sites. People, even to the point you made, Dr. Monroe, like being able to take on interns is another conversation, but there isn't a coordinating body right now, and we've started to look at that, including looking with the state chamber at the Work and Learn Indiana system, which has not historically included a public health component, but we've had some early conversations about that. So all that to say, there are some active conversations about that. And maybe that could extend to like the job board too, but so just wanted to mention that. The second thing, as we are looking at this, one of the things I have tried to do is work my way through some of the recommendations that came out in the original presentations over the last months versus what's here and things that we've talked about. And so one of the things that I think I'm not seeing, Hannah, is the regulatory piece, which I think we talked about there, and I'm not going to know the specifics, some of you know more, but with the pandemic, didn't we sort of enter into some like reciprocal relationships with other states and make some modifications around
Oh, I can comment on that.
So-
So we had a shortage of, like, for example, behavioral healthcare professionals. And so instead of having to wait and get certified here in the state of Indiana, if you are already certified in like Illinois or Ohio, then they would provide you temporary privileges until your process was continued.
Okay.
And they did that for, I know for the psychologists because of social workers, because of that huge shortage. And
Okay.
that's a state legislative
Okay.
bill that's been passed.
So I just wondered if there were any tools that we had used sort of temporarily that could be extended permanently to help.
So Kim, thanks. Thank you for asking about that. I think we actually did have some legislation passed this last session
Okay.
regarding and I apologize, I don't have the bill number right in front of me, but it was regarding issuing a temporary license within 31 days of application and then requiring the boards to respond and review the application, I believe within another 30, but please do not quote me on that. I will make sure that you all get the bill number. Did it not pass? I thought it did. Reciprocity?
Yes,
We will look it up. No, this is not temporary. This is law. And so I think, our lawmakers saw the value of getting people in quickly. I also want to call to note the legislation that was passed on nursing workforce because it expanded the pathways to licensed nursing for our qualified foreign trained nurses. So actually something we discussed in the October meeting has already been able to be solved. And thank you to those that champion that.
So is there more of that?
But what I guess I would say is these are very high level recommendations. And yes, there are probably likely other opportunities, which is why a comprehensive assessment would not just be quantifying. It would need to be assessing our regulatory environment, our wages, right? How we compare. So I would like to say that although it's very high level, couched within that comprehensive assessment and plan would be a review, not just of the county and the heads and those in actually engaged in or employed, but also what are the characteristics and how do our characteristics for our professionals and workforce compare on those various factors. So thanks for asking that.
Yes, Dr. Halverson and Dr. Box, I'm sorry.
I'm gonna give you my bullet points, okay?
I've been waiting.
Yeah, I've been waiting anxiously. I just wanted to mention to you, thanks Hannah for your good report. It's a great start, I think. But just to also add additional information, I'm very pleased to be the founding dean at the Fairbanks School of Public Health. And one of the nice things about it is to see the incoming freshmen and the number of hundreds of people actually who are working on their undergraduate degree in public health. I will tell you, we have the highest number of first generation students on our campus as a percentage. We also have one of the highest percentage of people of color and a very high percentage of Pell Grant recipients. That's all really, really good, but it underscores the comments that were made by Dr. Kane and others. These folks are really looking for and need paid internships because it's not that it's just nice to have some extra money. Many of these students are working 2 or 3 jobs or are getting other kinds of scholarships, and many of them really struggle to stay in school. And so having that paid internship is important because sometimes we require an internship, but they sometimes have to quit or diminish their paid job to be able to do an internship. So being able to get pay for the internship is really important. But even more important, and I think this goes to another point that Dr. Kane made, is the notion around competitive salaries in public health. This is a problem not just in Indiana, but especially in Indiana, but across the country, where we're seeing schools of public health where the vast majority of students graduating with a degree in public health do not go to governmental public health. And in large part, it's because most students have student debt and most public health jobs do not pay sufficiently to be competitive with other employers for the skills they're trained to do. And this is a huge problem and one in which we really need to embrace. And that goes to my first really important, at least in my mind, suggestion, Hannah, and that is we do need to have a definition of the public health workforce jobs, job families, job sort of typical job descriptions. Again, we do a very poor job of this in Indiana, but across the country. This is just, it's not an Indiana specific thing. We just have a hard time with it, and we need it because of all the reasons that Mindy and others have mentioned, but that includes job descriptions, education and experience requirements,
Importantly, pay classifications. And that is work that may not necessarily be able to be done by a centralized service, but needs to be done absolutely. And it's a critical component, I think, for any workforce plan that we might come up with. Secondly, I want to point out there's a board of public health examiners. It's a national board. It actually is issues a national board certification in public health, the CPH designation. A number of us really pushed hard to make sure that people with experience and a degree, and you actually only need to have 5 years of experience and a bachelor's degree in any subject, are eligible to sit for the CPH exam. That creates some leveling for us because so many people come to public health with different, degrees and so forth and so on. But we need to know that people have some core skills in public health. And so that board certification is really critical. It's been in existence now for almost 10 years. And it's a definite thing we need to emphasize in our workforce plan. Additionally, there's a public health job competencies. It was just recently revised and approved in October of 21 by the Joint Council on Accreditation in Public Health. It is very comprehensive, 3 or 4 different levels of work in almost each of the domains. And I think that's really important to pull on in terms of some of the work that needs to be done where we can actually specify job competencies and not talk in generalities around what needs to be done. This has actually been very well studied and I think can be included in our report. I also mentioned the preventive medicine residents. We have 0 preventive medicine residency programs in Indiana. We have a little over 100 physicians in Indiana that are board certified in preventive medicine, none of which are working in public health. And I do think there's a great opportunity to develop a multi-hospital system sort of collaboration around preventive medicine, especially as we move into value-based payment. So anyway, I think that's important. Also, that I think Judy may have mentioned that I would emphasize the Public Health Workforce Coalition, that there's a great brain trust nationally that's looking at all of these public health workforce issues, and I think we should tap into that. And lastly, just let me say, I have gone through a couple of times with these public health workforce plans at a state level. I get real concerned about the idea of including public health with the healthcare workforce, because in my experience, public health almost always gets completely drowned out by the many specialties of medicine and nursing, and then the scope of practice issues that invariably come up. And while I do agree and understand the importance of creating a sort of combined public health and healthcare sort of examination of the workforce, I just think we need to be especially careful that public health, because we do not have a strong lobby and we don't have a strong association, although I appreciate Kim's efforts, they don't have the 10 lobbyists that can come and sit in on those sessions. I just really feel like we really need to pay attention to public health, and invariably, I think when you put everybody together, we'll get lost. And I just have to say I'm really concerned about that. Although again, I think properly done, it could be very powerful, and I would support it. I just think we need to be careful. Thanks.
Thank you, Doctor. We're about to close on this subject. Dr. Box, did you have?
I understand what Dean Halverson is saying. I would say that if we don't solve the clinical healthcare workforce problems, they will just hire the public health nurses and other people right away from us.
I agree.
And then the second thing I wanted to say is one thing on the public health wins review from public health professions around the United States. It always says that people leave because they don't see a path forward for advancement. And so I think if we're trying to recruit out of high school and college and get kids interested, they need to see that they might be able to go into a job, get training in high school, go into a job, get paid in that job, and while at the same time getting educated for the next level. So CNA, LPN, RN, and I'm wondering if we shouldn't add a bullet point about that, because I think that is something that's really important for us to emphasize as we try to draw these kids in that really can't afford to maybe go to college right away, you know, that need to be earning some money when they first come out. Thank you.
Brian, and then Commissioner, last comment.
Yeah, just three quick things. I mean, I'm really glad that we're starting with workforce because I'm thinking about the tree kind of falling in the forest. All of the other stuff we talk about can't get done if we don't address this. There just won't be people to do it. I think the loan repayment thing, we talked a lot about internships, which I think is important, but it's what I think Dr. Halverson said about or the debt, right? That's I feel like it is a hard thing to fix. Government always has some restrictions and will always be a little bit slower to be able to catch up to market rates. But what we can do at the state level with a loan repayment program is change the economics for somebody that may be willing to take a slightly lower salary, but because they're passionate, they've been exposed to it, but then look to a longer term payoff, hopefully find other ways to keep them in the field. But I think the loan repayment is really where I think we would get the most bang for the buck. And the General Assembly has been really interested. Two really important bills, House Bill 1003 and Senate Bill 5, that was the bill with the timeline. So I think there's an appetite there. So I think we can look to how we maybe try to hitch a ride sort of on other discussions that might happen in the General Assembly to put together the budgets for higher ed. But I think the loan repayment thing is really the biggest kind of lever that's in here. And then lastly, I just want to say with Dr. Halverson's, I completely, I don't fully appreciate, you know much more about this, but what is involved with those competencies and those certifications in public health. I do think we should be a little bit careful of not making sure we are in any way narrowing the field when we really need to expand it. I feel like those are things that we need to work towards, but I wouldn't want to overemphasize them. I feel like we're in an early stage. We've got to sort of walk before we can run kind of thing. So I'm not sure exactly how you meant for those to be included in the report, but I just want to make sure we're going big and trying to get a lot of people into the system. We don't narrow it too quickly. Does that make sense?
Yeah.
Commissioner Dawes, last comment on this subject.
Thanks. Just a quick comment back on funding or pay. To me, when you pay an individual to do something, it says to them they have worth, that they have value. And so I think that's another reason to look at when you're paying it for an internship or a fellowship or whatever. It says to the individual, they have value, they have worth. They're not just a volunteer. And I think that's another reason there.
Okay, thank you. Well, this is good discussion. Pam, are you ready to go to the next discussion? Governance, services, and infrastructure proposed recommendations. Pam Pontones.
Good afternoon. Thank you very much, Senator Kenley, Dr. Monroe, Dr. Box, and all of the members of the commission. It's my pleasure to speak with you this afternoon on what you've heard already mentioned is absolutely foundational to the future of public health in our state, and that is governance, services, and infrastructure. And really foundational to ensure the availability of public health services wherever Hoosiers live. So it's my pleasure to speak with you this afternoon. As you know, Indiana is served by 94 local health departments that are mostly county-based and locally administered. So Indiana has a central or decentralized form of public health. And we've had that model in our history. While some local health department public health services and functions are statutorily prescribed, there is wide variation in the capacity of local health departments across our state to meet basic requirements of public health and to fulfill the other desirable roles and responsibilities that would really improve the health and well-being of Hoosiers across our state. So this afternoon, we would like to make and describe the following goals and recommendations to improve the capacity of local health departments to deliver a defined minimum set of public health services and functions while also respecting the local autonomy and ensure a local presence for public health in every county. So the goals that we offer to you this afternoon are, first of all, to ensure the consistent delivery of public health services across Indiana, that where Hoosiers live should not define the availability of public health services that they can receive. Secondly, to promote the collaboration and increase technical assistance that can be provided to local health departments to meet those minimum capabilities. To modernize the structure of public health, to be able to offer those services in a continual, robust way and meet the needs of the future. To enhance engagement with local community partners and elected officials. And we know that local capability, local representation, local response is so important. Encouraging the sharing of expertise and skilled professionals. We've heard again through Dr. Maxey's fantastic presentation, some of the workforce challenges that we have and the availability of some of the needed skill sets and expertise. So if we can share in a number of different models, that kind of expertise to increase the availability and reach across our state. And finally, to promote a culture of continuous quality improvement, to continue to meet the needs of communities and future public health threats. So I'm going to list some draft recommendations for you, and then similarly to Dr. Maxey, go through in a little bit more detail what those recommendations might entail. So first, to establish baseline service standards modeled after the foundational public health services framework. And you do have a copy of the latest 2022 foundational public health services from the Public Health National Center of Innovation, which is an arm of the Public Health Accreditation Board. So you have those for reference. We also recommend expanding Indiana Department of Health resources for local health departments and interlocal collaboration, county to county or within districts. Assisting local health departments to engage local partners to promote public health in the community. And having that local capacity is so important. Updating local health board appointments to reflect current public health workforce and key community representation, such as that from key cities and municipalities within that local health jurisdiction. To ensure that policy supports the sharing of resources between and among local health departments. To create a moratorium on additional municipal or city-based local health departments. Right now we have 4. We have Gary, East Chicago, or 3, Gary, East Chicago, and Fishers. So creating a moratorium on additional municipal local health departments. Expand the personnel eligible to serve as a local health officer and who can maintain that function. And then finally, to provide financial and technical assistance to local health departments pursuing accreditation or reaccreditation as set forth through the Public Health Accreditation Board. So I'll walk through these in a little bit more detail for each one. First of all, draft recommendation number 1, establishing baseline service standards modeled after the foundational public health services framework. And again, you have that copy, as well as a handout of talking points geared for policymakers and the public, just to keep in mind. Indiana is now, I'm proud to report, joined the 21st Century States Learning Community, which allows peer-to-peer learning and discussion of the foundational public health services framework and other aspects of public health modernization. So very pleased to share that with you today and look forward to further engagement with that national organization. So possible action items around modeling our foundational public health services around that framework are, first of all, to define required services. What is the minimum, the baseline public health set of services we want to see in every jurisdiction within our state? And making sure that we include stakeholder engagement with that. Again, hearing from local officials, from local jurisdictions. Secondly, to provide technical assistance to local health departments to support them in the implementation and the sharing of resources. That's a new paradigm, what that looks like, being able to provide that technical assistance to them. Draft recommendation number 2, expanding our Indiana Department of Health resources to be able to support local health departments and interlocal collaboration. And around that, potentially providing staff and resources to support local health departments in a public health preparedness district with epidemiology, data analytics, legal analysis, communications, grant writing, and other functions as necessary. And you heard me describe back in December through our survey data what local health departments would like to see in terms of staff and resources for those shared types of services to expand their capacity. Secondly, to encourage partnerships among local health departments for key service areas, such as tuberculosis case investigation, sexually transmitted infections, lead case management, where some local health departments may see this quite often and have the capacity to effectively meet those needs. Other local health departments may not see those very often, and there may be some capacity gaps to be able to address those issues. Draft recommendation number 3, to assist local health departments in engaging their local partners to promote public health in the community. So making sure that local health departments can serve as that convener, being able to engage their partners, folks that they have relationships with and know best, and how to establish new relationships with new partners, including providing local health departments with guidance and best practices on how to create those partnerships, convene folks to the table, and then sustain those strategic relationships. Another is to sustain partnerships and collaborations developed during the pandemic. So we saw a lot of new partnerships and relationships growing out of necessity. Now, how do we maintain those and take them to the next level so they don't get lost because maybe our response has shifted? How can we apply those to other public health challenges and initiatives? And then finally, partnering to promote the importance and the value of local public health. Public health is where you are. That was the theme of National Public Health Week, and that's really where it begins. You heard before, all emergencies are local. Public health initiatives are local. So how do we promote the importance and value of local public health? Draft recommendation number 4, updating local health boards and appointments to reflect current public health workforce and key community representation. Possibilities include increasing representation from key municipalities and deepening the coordination with local government, the relationship between the local health department and local key elected officials, and ensuring that understanding of public health needs and resources. Allowing the appointment of master's trained public health professionals to local health boards. So we have that knowledge base included in our local health boards. Draft recommendation number 5, ensuring policies that support the sharing of resources or consolidation of local health departments if that's what's desired by local partners. Some possibilities include ensuring that the creation of a multi-county local health department, if the decision locally is that we're best served by merging a couple of local health departments, for example, making sure that does not result in lower overall funding for that combined entity. As we've heard some of the concerns voiced in the past, if we do merge, what does that do to our grant funding, potentially federal funding? Secondly, Indiana Department of Health will provide technical assistance for those requesting counties that are considering local health department consolidation, helping them or at least see what the pathway might be and what resources they might need to do that. That might include legal consultation, model ordinance language to be able to merge, and a toolkit with other recommendations and guidance, so that if we get the question from a couple of local health departments, well, what do we need to do to merge? We can provide those resources right away to put them on an effective path. Thirdly, for counties choosing to form a multiple county local health department, amending the statutory language to require that the resulting multiple county local health department maintains at least one physical office in each component county, so that at a minimum, residents have consumer access services such as vital records and immunizations still located within their county. So even though we might have a combined local health department, we still have those essential vital services available in every county. Draft recommendation number 6, creating a moratorium on additional municipal or city-based local health departments. And some possibilities include, first off, amending or repealing Indiana Code 1620-4-5 as needed to grandfather our 3 current municipal local health departments, but prohibiting the creation of new ones and really focusing on the county-based local health department. Each of those 3 grandfathered municipal local health departments would be required to enter into an annual MOU or memorandum of understanding with their respective county health department, so that at a minimum, that addresses the planned services, the funding, and the data sharing to support the delivery of basic services within the county. So if we do have a county that has both a county-based and a municipal local health department, that there is a memorandum of understanding between those 2 entities for coordination and purposes of planning those services moving forward. And finally, Indiana Department of Health funding of municipal local health departments is conditional on our agency approval of the annual MOUs, memoranda of understanding, between each municipal local health department and the corresponding county health department. So having not only the MOU between the municipal and the county health department, but then also making sure that there is approval of the funding of those municipal health departments, again, for accountability and coordination. Draft recommendation number 7 is expanding the personnel eligible to serve as a local health officer, again, meeting capacity needs where they exist. Our current statute requires that all local health officers hold either an MD or a DO degree. And what we propose is allowing individuals who are advanced practice nurses or physician's assistants with formal public health training to serve as local health officers, again, expanding our capacity. And we've heard of challenges in counties where it can be difficult to find a medical doctor, physician that is able to serve as a local health officer. So expanding that eligibility pool of folks who can effectively do that, while still ensuring physician oversight from either the local health board or a neighboring county to perform the required clinical supervision under the current scope of practice. So making sure that an advanced practice nurse or physician assistant has the medical oversight necessary to be able to fulfill that function. And then ensuring that advanced practice nurses or physician assistants who are functioning as local health officers can issue standing orders related to their office, just like we see local health officers, our state health commissioner doing now. And last but not least, draft recommendation number 8, to provide financial and technical assistance to local health departments pursuing accreditation or reaccreditation through the Public Health Accreditation Board. Some potential action items including providing technical assistance to local health departments that are pursuing full accreditation. I did see today where the FAB Pathways to Accreditation program has now been released, which is another avenue for local health departments wanting to pursue accreditation, but maybe they're not quite ready for that full accreditation process. This gets them on the road to be able to do that. And then finally, assisting with funding to defray the costs of local health departments pursuing accreditation or reaccreditation. And we've heard that there are local health departments that would like to pursue this. They would like to make sure they're meeting those standards and measures, but sometimes can be cost prohibitive. So assisting with funding with that particular endeavor. And I will go ahead and stop there. That concludes what I have for you today, and willing to open it up for questions. And I'll go ahead and stay here.
Okay, thank you, Pam. When you talk about combining departments, I assume that that's somewhat of a reference to the fact that more than 60 of our counties have less than 50,000 people, and 30 of them have less than 25,000 people. And it's difficult to have the financial resources at that level for them to function. So you're thinking of encouraging some combinations there, and you even mentioned incentives. I think so. To do that, it might be that as we go to the legislature and we get not only a bill passed, but we get funding for this, it could be that we need to evaluate or analyze whether there might be some kind of assurance or even a bonus or a copay, lowering of copay for those rural counties to try to do that. Is that kind of a takeoff from what you're saying here? Is that within the realm of what you're thinking about? Are those issues you're trying to deal with your recommendations?
So, and that's a very good question. What we, in really looking at this, putting this in the hands of local health departments, if they have issues or challenges with being able to provide those essential public health services in total themselves.
Right.
Then if they're in, and there are some examples for this, but if they decide with a neighboring county, perhaps a neighboring county has similar issues or a neighboring county is willing to help, then if they decide locally that that might be an avenue in order to provide those services, then we would be looking to be able to provide the technical assistance for them to get on the path to do that.
And so as you think of this, is there some of this three-tiered element in the presentation? You've got the state health department, and then you've got these districts where maybe you have specialists that go out and help these, and then you've got the local health departments, right?
Yes.
Yes.
Okay. And then the last question that I had was on page 11 on this draft recommendation 7. I don't know what a standing order is. I'm sure everybody else does, but I have no idea.
For instance, the state health officer would give a standing order for people to be immunized. So that another doctor doesn't have to get that order.
Okay. All right. Thank you. Commissioner Dawes.
Thanks. Appreciate this a lot, and support especially the areas that talk about, combining. We used the term as we went through our process, regionalization type things. And as I've talked to other commissioners in other counties over the past couple of months, I have not received any pushback in a negative way toward combining, regionalizing things, so on. The concern that I hear deals with more local control.
Yeah.
How can we have local control? So I think that's something that we need to keep thinking about. If we would combine 3 counties to make 3 20,000 population counties into an area of 60,000 people and have one local health department, how does each county have input into the governance of that entity? The other thing I heard, and it goes back to, and Brian will appreciate this, even though I don't think he was that involved when some of it changed, but county hospitals in the state of Indiana, for their boards, used to have a requirement that it had to be a bipartisan political board. And so you take a county that, like where I live, where it's hard to find Democrats to put on a board, maybe, and I know that seems to be a factor that exists right now with local health department boards, that they have to be bipartisan politically as well. And so maybe that gets done away with and you go after good people to be on that board, but don't worry about the political party they're in. And so that's another thing brought forward. Again, when I talk to other commissioners, that somebody even told me that they had a veterinarian that they wanted to serve on a board, but they were the wrong political party. So the next year, that veterinarian registered in the other party so that they could be on that board. And so, you know, I think that would be good to look at that. The other comment deals with best practices, and you did touch on some of that in here, and I forget which recommendation it was in, but I think that's a critical part of governance as well as is the best practice area. And if some of the expertise, and I like that in here, can come from this, the state is not controlling it, but if some expertise like epidemiology and so on can come from the State Department of Health, that would be well received, I think. So, comments, thanks.
Thank you very much.
Mindy and then Dr. Welsh.
Mine are quick and easy and just suggestions. Great job, Pam. Appreciate that. On page 6, hoping we could, I know these are high level draft and can always change, but if we could put in under A, training as well as one of the other supports, then I think you hit all the things. Oh, sorry, page 6.
Page 6.
Okay. Under A, when you hit kind of the support, if we could add training, just so it's there from the beginning, I think that's very helpful. And under B, when we encourage partnerships for these key services, which I do think is a past thing that was done and it was very effective in certain topics like you suggested here, but there was funding at that time and that made it attractive to those who did provide the service for that area. If we do it, I think that's what it would take to make it successful again. The reason most of it went away was because the funding did not pay for the service in an area.
Okay.
So just a suggestion to make it successful, that might work.
So for, just for my understanding, so for the local health department providing that assistance, having some funding tied to that local health department providing the assistance to another county.
For instance, we have an STD clinic that nobody in our region does. So people come from all counties to seek our services, but we're not compensated for that. So we used to be, and those are ideas. TB is another one's a very good idea. So it's just something as an option. I don't know. On page,
Mindy, pull that mic a little closer to
oh,
you.
sorry. Okay. On, I covered up the page. Oh, page 8. Along the lines of the statute regarding boards, I wonder if maybe it's a variance, because it does say currently about the no more than a certain number of political affiliation in the statute currently on boards, but it isn't policed and it's widely not available to be done in some counties. So I wonder if there's instead of abolishing it, which I think might hurt some areas, what if it's some sort of a variance process where in an extreme circumstance, like now, when you can't find a specific doctor to be a health officer in some county, there's some things that you could vary on. I wonder if we do that versus going to the extreme cookie cutter, just doesn't always work. So just a suggestion. I don't know what others think of that, but it does need change. That whole statute is archaic.
Which one?
The board statute.
Who
So-
composes the board?
So did you hear what I said, though, to make it a bit of more like of a variance in an extreme circumstance when you can't find that versus it being,
I'll wait for make my comments.
okay.
Dr. Welsh. Oh, I'm sorry.
Yeah, I'm almost done. Page 9 on C. If there's a way to add, you had 2 pillars covered, so vital records and immunizations, but the other pillar is the environmental side. So the inspectional / permitting, that would likely need to remain too local for several reasons. I don't know if we could at least put it in there for consideration. And
So Mindy, I'm sorry, that's food safety and septic permitting would be the 2 things.
any of the environmental, yeah, because lead is now a requirement. All those things are, I shouldn't use that one because that one could be done as shared, but the permitting ones, if they have to travel to get permits, because there isn't a lot of online stuff happening, I don't think some of these folks will get those things done. So the 3 pillars generally are vital records, immunizations, and then the environmental health, just as a start. Okay. Obviously. And then my last one is on page 11. Yes, okay, so under B, really.
Mhm.
On the local board assistance or oversight for medical, in a survey with that across the state of several years ago, most are unpaid, relatively uninvolved just for certain meetings, and they're not generally covered for liability. So there'd be a lot of change there needed to make comfort level if we use local health board oversight for medical coverage in our clinics. I don't know, that's just our thought.
Dr. Welsh had brought that up to me too.
Oh,
Many of them
okay.
Are retired and don't have any.
That's
coverage.
correct. Okay. And if that's your only option, I think it could be an option,
Yeah.
but if that's your only option or a
May
real
not be a good one.
greased allowance, I think there'd be a lot of logistic hurdles with that. We currently have that now.
Dr.
thank you.
Welsh?
Thank you. Pam, great presentation as usual. The good news is a lot of the stuff is already being done, but not codified in rules and regulations. So 1, 2, and 3, I think are fantastic. I think giving folks a framework, it's like, here's what you should be shooting for. Here should be your goals, and then support how to do that. And quite frankly, just so the public knows, the State Department of Health has done a lot of these things, even though they're not required to do so. They have been wonderful partners with the local health departments, facilitating information. On recommendation 4, I guess I would want to defer to our elected officials how that would be handled in different counties. I think it's a great idea. The more of the small towns that are involved in input to the public health in their county, I think is a good thing. But I would want to defer to the elected officials how that would carry in different counties. I know there was, for instance, in one county I'm at, the one city, one town was able to give a recommendation. And then it turns out they were technically under the size limit. So the county kind of pulled that option from them. But I think this would be a good idea. The question is how it would work among the local elected officials. On the last, and I think on the last one is a great idea. Ripley County was close to the process of getting accreditation before COVID hit. And I know some of the logistic and funding issues were kind of slowed us down, or we would have gotten there. So that gets me to recommendation 7, and Mindy already mentioned one of the things. So a lot of the physicians that I'm familiar with who are on the local health boards are retired, and they do not have coverage. The second thing is if one of those is still in practice, when you get your medical malpractice policy each year, they often ask you whether you are supervising any APRNs or PAs, and then your bill goes up if the answer is yes. So some of them for the small stipend on the health board may not want to take on that added cost. We get also into a logistic situation where these professionals don't have independent practice so far. And I think that we may want to revisit the question when they do get when they are able to practice independently, but it can present problems, especially if there's any conflict between the health department and the local elected officials. They may have trouble kind of carrying the weight, where even the current docs, MDs and DOs are having some issues trying to convince in some cases. I think one option where it might work is if you had in a region where you had a health officer or a regional health officer covering multiple counties, and then you may want to, in order to not totally burn out that individual, you may want to have the option where they can have someone in the in one or more of the counties in this professional background. So you can have, say, a regional health officer covering 2, 3, 4 counties, which would be a lot for them to cover all the things, and then having an advanced practice nurse or PA with public health training may be something to help kind of fill in, so that we don't lose that health officer covering multiple counties.
Fantastic. Thank you very
Yeah.
much.
Dr. Kane and then Dr. Halverson.
Okay, so I guess I'm a little two issues with the advanced nurses and the physician assistants serving as local health officers. I want to be clear about the coverage from the physician side. So a lot of times for us, a lot of our recommendations had to be with a lot of the physicians in hospital settings. And so it is so much easier to get compliance with our physicians if they think it is a person who is sort of actively or very recently have been practicing medicine. So I want someone telling me or making recommendations who knows where my reality is, understands what's happening in this practice and dealing with patients versus someone who, they may have read the textbook, but they don't have a clue about reality in terms of what patients do in hospital settings or clinical practices. So making sure I still have that physician support, talking to their peers in terms of doing the influence. So and so I don't know how, I just need to feel more comfortable how to make that happen. Because otherwise, in points of crisis, it takes a much longer period of time for someone making recommendations to them that may create some hardships or some major challenges and barriers, and they're just not hearing it. And it has been so beneficial for us that a significant percentage of our health officers are actually practicing, and they know their colleagues very well because they're seeing them in the hospital setting. So whatever way this recommendation works, I would not want to lose that particular strength of networking. So now, do I know that nurses can be very talented and run a health department or physician assistant? Of course they are. I've got some great colleagues who've been director of the health department for Boston, been the health director for Portland. Maryland, been some of the smartest folks I know, but still for the climate of Indiana, you need some physician support. So I just want to make sure I don't lose that. So that's my first point. I'll be real quick. My second point is for the public health hospitals, about getting rid of that bipartisan requirement. Commissioner, I'm a little bit more uncomfortable about that just for the city of Indianapolis. Bad or good, it forces us to have to, at least from the public health standpoint, it forces us to have to talk to both parties in terms of trying to get a consensus because of that bipartisan piece that was put in there. And I can tell you from a political standpoint and from a science standpoint, I think we have benefited from having a bipartisan board because of the different perspectives. And it's forced us to have to figure out how to work together and compromise in some areas that I think has been beneficial for the community. So I just don't know what happened and what it would look like and what the outcomes would be if we didn't have that requirement for our county hospitals. And I want to say I'm a practicing physician. I practice out of I think it's the 5th largest public health hospital in the country. And we've just been very blessed to have remarkable chairs. And basically, depending on who the mayor is the majority on the board. So we've had Republican mayors, we've had Democrat mayors. And so the mayors and their city council still control the majority who's ever on that board, but you at least hear some voices. from the other person on the board, so.
Dr. Halverson.
Thank you. I'll try to go fast. One, I'd just like to get on the record, the need for us to rewrite the public health statutes in Indiana. They're way overdue. They need to be done. It just needs to be on the to-do list. Two, as it relates to the recommendations relative to the state health department's support for local health departments and interlocal collaboration, I couldn't agree more. I think this is wonderful. This is a great recommendation. I would just say, based upon my experience working at, this is one of the first jobs I had when I was at CDC, was working with state health departments and the group called the state local liaisons. And the one thing that we did learn, and I would just pass it on as a tip, is that the person that's in that role really needs to have incredible depth and experience as a local health officer and in having the ear and the clout within the state health department. And when they do, they are incredibly effective, but they have to be empowered by the state health department to actually make things happen for the locals. And they can't say, well, I got to get around to finding 18 other people. You have to have enough staff working in that office that can actually make things happen, and people that can make commitments to the local health departments to actually get things done. And that's a huge issue. And I will tell you that most states do this job very poorly. So if we could work on really trying to beef it up, I think it could be an incredible part of the success of this work and this partnership. On number 5, the recommendations related to mergers. Again, our chair has made the comment around mergers. I would just maybe think about suggesting mergers and resource sharing and innovative organizational strategies. There's a lot you can do short of a merger. And I don't want anyone to just run away because they don't want to merge. Because I think you're right, Commissioner. I think that there's a lot of concern about lack of control and losing their voice. And so I think there's a lot we could do, and I just want to leave that open as a possibility. On number 7, I'm going to talk a little bit about the on number 4, expanding personnel eligible to local health officer. I'm going to talk a little bit about that, but the bottom line on that is I think we need to be clear about public health training versus medical or clinical oversight, because I think we mix up these things sometimes, and I think we really need to emphasize the public health training. On financial and technical assistance to local health departments pursuing accreditation, and I noticed that there's extended recommendations, and again, I would say in full disclosure, I'm finishing my term on the Public Health Accreditation Board, but one of the things I can tell you is that local health departments that are accredited do better. They are much more accountable to their local community, and they get better results. And so I guess the question that I would have is, we need to have strong incentives, if not mandates, to move towards accreditation. And we need to put a long on-ramp so that accreditation can happen over time in a way that's feasible and plausible. I know that there are some states that have put mandates in place. They've had pretty good results, but I think ultimately it's not about the mandate, it's about creating strong enough encouragement that the local health departments do become accredited. And also kudos to our state health department that is one of the strong state health departments accredited by the accreditation board. But I definitely think we need to be less than passive on the notion of on accreditation. We, if not mandate, at least strongly encourage or facilitate or create incentives.
Got to have money or resources.
Exactly. Okay. Well, but yes, but that's part of what we're going to talk about, not today, but later, right? Resources. On the issue around stakeholder engagement, I love the foundational public health services. I think that's exactly where we should go. And to Pam's point, the notion is that it shouldn't matter where you live as to what public health services you get, at least in terms of the foundational services. But I guess I would suggest that we need to set the floor, not the ceiling. So we don't want to inadvertently create a disincentive for local health departments to do more than what is in the foundational capabilities. Although again, if you follow that that schematic, I don't really think that's going to be a huge problem, but we want to make sure that we don't disincentivize creativity and innovation. And I think I'm almost done. I guess the last part that I wanted to talk about was related to the idea of local health officers. And again, I think sometimes we mix up the issue of medical clinical oversight versus public health training. And you know, as our public health statutes were developed in this country back in the late 1800s and the early part of the 19th century, the issue is that we didn't have public health training. And so it was natural that I think that physicians were called upon to be our health officers, and they did a wonderful job. And in Indiana, we're blessed with great health officers. But we've got a big problem in that most of our physicians really have no training in public health. They're incredibly smart people. They do a good job. And in Indiana, you have to be a licensed physician or to be the county health officer. In my view, I think that's great. We need medical engagement for clinical oversight, but more than that, and I think Dr. Kane mentioned this, it's crucial to have an informed interface with the local medical community. So I think that our connection with our physicians and our counties are really critical. I guess what I would just say that we ought to take a look at is to perhaps disentangle the whole notion of the leadership and operation of the day-to-day work of the health department from the function of medical and clinical oversight. Now, to be sure, I think that there are large health departments that really benefit from having a public health trained physician as their chief, and we ought to continue that. And I also think it's really important to recognize that many of our local health officers, they may not have started with public health training, but over the years, they've had incredible on-the-job training that has given them terrific insight and has qualified them to be health officers, and they're doing it great. And some of them are doing it for free. So that's terrific. But to the extent that we have people that are just meeting the job requirements because we have a statute that requires a physician to be the quote health officer, and we vest enormous day-to-day operating responsibility to that physician, it really is out of step with the rest of the country. I mean, in some cases, what we're doing is we're adding substantial costs when they are being paid, or we're adding a tremendous burden both to the health department and to the physician by requiring them to provide a service when in fact their training is not in public health, but is in medicine. And eventually they get it, but not immediately. And so I know I'm going to get violent opposition, but I'm going to say it anyway, because if I don't, then shame on me. But so we need a plan to move forward to support our training, our physician health officers, and we need to establish standards moving forward to assure that public health trained people are directing and staffing our health departments. That's not just the leaders, but we need just general public health staff that have public health training. And again, I think that there are incredible physicians that are acting as health officers that are doing a wonderful job, and to the extent that they want to continue, they should do that. But I think our job is to be looking forward to developing a plan that says, what's the best plan forward? And my question is whether or not a health department that serves a small population needs to be led by a physician health officer with no training in public health, but interest in medicine, which is great, but I'm not sure that ultimately that serves either the state or the people with the best service. That's it.
I just want to note we have 12 more minutes scheduled on this work stream.
Kim, and then Brian, and then Dr. Kane, you're on the cooling off stage. And then Dr. Monroe.
Dr. Monroe first.
Yeah, please go ahead.
Oh, me, okay. I can be very quick. I love having accreditation in here, and I would like to see if we could do more, like, again, executive or administrative action, sort of build in elements for health departments that may not get to full accreditation. So are there things we can take from accreditation and require without the accreditation process? I too am not clear why we would not want our trained, especially doctorally trained public health professionals in leadership roles. That it sounds like I don't understand all the discussion around number 2, the point B, but it sounds like there are ways to work around it so that you can have leadership that isn't clinical. And I too was hoping, and it had been come up originally just for an overall modernization of the code. So I think even if it's a follow-up step to this, I think if we don't revisit the code overall, we have missed an opportunity.
Brian, go ahead.
I just want to say a couple quick things. I do think I understand we need to talk about these things like accreditation, but I do think we have to recognize that it is still somewhat aspirational. Like I think we really have to be careful about doing anything that narrows the pool of people that we need to bring into the system right now, because we've already talked about the deficiencies that we have in the system, and then we have this healthcare workforce crisis on top of that. So I think we need to be careful we don't tie ourselves off, and maybe there's a kind of a part B or something that follows. Recommendation 2A is super important. That's the thing that I kind of think there's lots of good stuff in here, but I think I'm most excited about. And I think back just sort of during the pandemic and looking at all the amazing work that Dr. Fox, Dr. Weaver and did. And I think that high level position is important, as Dr. Halverson said. The regional hands-on kind of approach is going to be critical in just identifying where those opportunities for efficiencies come from. So I don't know if it's deputy commissioner level, but a high level person that's working with 3 of the regions. We've got the emergency preparedness districts. We talked a little bit about that. I think I don't know. You get those down to maybe it's 9, and then you have a very high level person that's constantly working with and just knows intimately maybe 3 regions, right? I don't know if you have 1 for each person, but that's what I think. I know it depends on resources, but I'd love to see a little bit more of what the aspirational kind of org chart looks like. So how is that high level person at IDOH? Because when they're having those conversations with, as Mindy was talking about, the monster.com, hey, we were just talking the other day, and on the call, somebody said, I need this person. Well, so do I. Well, could we go together? Could they cover this position for both counties? And then the other piece that Senator Kenley started to talk about this, or intimated, kind of, this is important. What is that upside? So what then if I'm that person who's the liaison of the department, and I've got 2 counties who are saying this particular responsibility, there's an opportunity to come together. It's not a full merger, but to align those services. What's the sweetener? What's the incentive that I can say, well, if you do this, we can help you subsidize a little bit that salary. Now you've got it taken care of for 2 counties, and you've got a position that's more market level. So I think number 2A, what that support looks like and where it sits within IDOH is huge. And I think those people, those individuals are going to be the ones that uncover a lot of deficiencies.
Dr. Monroe, and then Dr. Kane, and then Dr. Beal.
Yeah, thank you. So I guess mine's more of an observation and a clarifying question between Dr. Halverson and Dr. Kane's referee. I think that might be my job as co-chair. Right? Yeah, exactly. So I think, Dr. Kane, you're making a really interesting and important point about a physician that is connected clinically, is seen as having that. But it also sounds to me like the model here, especially for smaller counties that would want to do some type of working together. And if you have a district level physician, a district or regional level, they could do the standing orders, couldn't they? I mean, you could have that individual do the standing orders. You wouldn't necessarily have to have a clinical, a PA or an advanced practice. You could have someone that's very strong in public health who's really leading that local health plan. To me, you're getting the best of both worlds. Now you're building a really strong infrastructure complementary of the different skills. So I'm hearing harmony. And a fantastic system that's being developed. I'm a realistic optimist.
That's good. I like that. Dr. Kane?
Notice I said large cities should have a physician
So-
health officer. Go ahead.
Right. So we actually have, what is it, 94 counties? 92. We have 92 counties, but 94 health departments. And Paul, the question I will ask you, how many physicians are there in the state of Indiana that has an MPH? So you may put a requirement here, and we don't even have 50 or even 25 physicians with an MPH. I'm going back with Brian's point. You put in these requirements, we have a shortage. And so that means if I want a physician that has a MPH, I've got to try to figure out how they want to come to Indiana from some other state when we got some of the lowest salary. Tell me how to make this.
My point.
No, I don't think I missed your point.
I'm not suggesting I'm not suggesting that. I'm not suggesting that every health officer should have an MPH. First of all, you could be trained in public health and not have an MPH. So there's another avenue. But then secondly, what I'm suggesting is we continue to have health officers that are physicians, but we also have people that run the health department who are vested with the responsibility to run the health department, who actually are public health trained. And again, there's a lot of definitions of what public health trained is. It's just that we have in statute the responsibility to actually run the public health department vested with a physician who probably does not have any public health training. And what I'm just suggesting is change the statute to allow someone other than a physician, particularly in a small health department, to run the health department. And that would allow us to be consistent with the rest of the country. Nobody else does this.
Well, I don't think health officers run the health departments right
See,
now.
it's the-
That's the point.
My experience
That's
is
the point.
they don't run it.
But look at the statute.
But are you making the administrators still be required to have an MPH?
What I would suggest is they be public health trained. That could take on the form of board certification in public health. It could take the form of an MPH. There are a lot of different ways to do it, and you can create an on-ramp and you could grandfather current people. You could also say after a certain point, 10 years from now, or you could create, and many states have done this. They've created qualifications that ramp up over time that allow people to get to that point. So I fully agree. We don't have enough people trained in public health, but we need them. That's all I'm saying.
Well, Dr. Veal actually represents rural health, so let's let her weigh in.
Which is really why I love the thought of allowing APRNs or PAs or non-physician providers to be able to serve in that role. And actually, that's part of my comment. I completely echo Dr. Halper said. I think our statutes just need to be updated. My concern with it's not really a concern because it's maybe I'm thinking too far into the weeds. That wouldn't be a statute, but if we put the language on draft recommendation 7 under the second item under B regarding physician oversight, and we do see the change with APRNs to be permitted to practice in Municipal, does that require statute change? And I don't want to have to go down this rabbit hole again. So I don't know if it has to be, if that would be a statute or if that would be part of their scope, like the practice.
I would be happy to speak to the regulatory structure. In the state of Indiana, we actually do not have a license for advanced practice registered nurses. So we do for PAs, but not an actual issued license from the state for our APRNs. So they're registered nurses who may or may not have prescriptive authority and hold that license. but they have completed a master's of science in nursing. So I do have some concerns that potentially there could be a massive regulatory overhaul potentially to get to the point that we would be able to have APRNs easily recognizable through a state credential. Now, if there's interest in establishing an APRN license, which many states have a registered nurse license and a separate APRN license, then it's most actually. It's most, I'm sorry, it's most.
No,
Okay.
I
No, it is,
didn't
it's
know. I
most.
didn't know. I was-
Most states actually have the LPN, the RN, and then they have an APRN license that is required to be issued in order to practice within the state as an advanced practice registered nurse. Indiana does not have that. So in my mind, that is a potential challenge. And so amend the statutes, or that could look like a very large overhaul
I
of the
think we're
nursing
saying, I
practice
think we're
act.
saying the same thing.
Yeah.
Like, I wouldn't want to put it in here as a recommendation to spell out what would typically be outlined in the State Practice Act for each individual license or certification, or in this case.
This is a good catch. And this is one of the kind of things that we need to continue to work on here.
Yeah, I just wouldn't want to have to go down this again to go, oh, well, now we've changed the State Practice Act for APRNs, but it's outlined in this statute for.
Meaning they could function independently without any physician oversight.
Yeah, when we get to that point, which I think Indiana probably will at some point, then we'll just have to go down the road again if we make it
That's the
specific.
whole scope of practicing.
Right.
We
Yeah,
don't
and
want
I
to-
don't think.
No,
this-
that's not for
no.
today's conversation.
And I was not saying scope of practice, so
No,
to
I know
clarify,
you're
I
not.
just mean a credential as a
Right.
recognized licensed
But we
occupation.
do figure it out when it comes to giving them prescriptive authority.
Mhm.
I mean, it's interesting that we've done that without licensing them differently.
The only other thing I was gonna say, I never even thought about it, I love Minnie's idea of having some sort of a variance for local health boards and the political preference or the political designation. Because I know my own personal county health department, county health board, they called me, were like, unless you're a Democrat, we want you if you're a Democrat, but we don't if you're not. And it's nonpartisan, so what does that say? And so I think we still restrict participation on those these other boards for inadvertently.
Mayor.
I know that Shane's anxious to get on to the next session, so I'll be very brief, but Pam, thank you for all the work here. It's no surprise that this particular component has garnered so much conversation. The success of this commission, in my opinion, is going to really hinge upon good policy and great investment. And that's going to require a tremendous amount of consensus building with legislature, local policymakers, practitioners, constituents, stakeholders, and the governor's office. And so I'm a little cautious about when we get into the policy discussion and the governance, because a lot of the state statutes that govern public health and particularly local health departments, is from the 1990s. And so I think that there's going to be a bit of an institutional mentality that's going to hang on to a lot of that authority that was given to those units of government. And there's going to be some reluctance of letting go some of that, particularly in getting back to the commissioners and Brian's and everybody else's comments here. We got to make sure we have buy-in. And that buy-in is going to be about making sure we have great representation across them. But it's also more importantly about what is the value proposition. I think it's the point Brian was getting to, is what are we going to be able to demonstrate to the communities that regionalizing is going to provide better outcomes than being independent like they have been for so long. There's also a concept that transpires all through the state statutes about home rule. And that's where I think there's going to be some reluctance with taking away authority or creating moratoriums that take power away from communities of doing what they think is best for their constituents. And I know we need to drill down and narrow this down, because what we want is consensus, and we want the outcomes to really rule the day, and maybe not have as much conflict as we're going to have when we're talking about who the policymakers are. But I'll also mention too that there are successes where regionalism has worked very well. And I think is probably the verdict is still out on whether it's worked. And I'll give you two examples. One is on economic development. The Ready Grant program that Governor Holcomb and the legislature launched last summer is working very, very well, taking a regional approach where we're collaborating and generating a lot of economic development through regions. Where I don't think it's worked very well is trying to bring county jails together to where they're operated across borders. I have a couple of commissioners here that might say that. I know in our own community, we opted to build our own $45 million jail, right? Because it's so hard to create these interlocal agreements that are necessary. You refer to them as MOUs. In our vernacular, it's interlocal agreements. It's also governed by state statute. It's hard to figure out all the who's and who manages it, who funds it. But the value proposition, we have to keep coming back to the value proposition. We need to have clear-cut objectives and what is the value proposition, and sell the investment and sell the value proposition that the outcomes are going to be better rather than just changing structure. And so as we get through a lot of this process, drilling this down into things that are very specific and measurable are going to be extremely important, because keeping in mind that we have to sell this to a whole legislature and to the governor and then all of these other policymakers as we go through from the state down to the local levels is going to get very, very complicated. And I think we have to be very specific and very simple and not take for granted all of the input that these local policymakers have had for the last 3 decades and still want to have input.
Sure.
That's a very good summation, Bob. And I think it really goes to the core of our challenge here a little bit. And we think that, for example, by having these multiple Zoom meetings, over 30 of them now, with different groups, and with having these listening sessions and circling back to the local elected officials, particularly the county commissioners and the county councils, and we appreciate you guys' help on revisiting them about these things. That the selling of the value proposition is what the document needs to really reflect. And so as we work through that, all the suggestions and the details that we've gone through here today, and we're going to go through next month on the next 3 areas, I hope you all will give us a little license in crafting the ultimate document to produce the sales value there that we want to do. And if there are things that you're really concerned about, we want you to circle back and talk to us again. But it's going to be pretty hard to put in the value proposition and get into all the nitty gritty of all the other things that we've discussed. So that's I appreciate you saying what you did in the way you did. It adds to the conversation here. So, yes, Virginia, one more thing. We need to turn to the next
Okay, just
subject.
real quickly. I really appreciated your comments. And I know we talk about, we may have these statutes back in the 1990s, but I'm also very concerned unless we've laid the proper groundwork, spent an enormous amount of time, we could do ourselves great damage by trying to change our statutes and find out we've got less authority, less power to implement public health because we've scared people in the sense that, hey, I need to make sure I still have my control. So when you talk about regionalization, unless we can couch it where they still have their own control, that's scary to people. And we may get the opposite results that we were trying to do. And so we really need to know our climate, what's going on now. And there's a time for everything. And you have to figure out what is the appropriate time to approach our state legislators. And I'm not sure to change our statutes. This is major changes. This is the time to do this. This is my first point. Secondly, with accreditation, I love you dearly, but any mandates for accreditation? Hey, we don't have enough resources to do what we're doing now. And so to figure out how to take the time in order to do and lay out all the work for the, to be accredited, that requires significant resources. Now, I'm about to undergo that process, but it takes a lot of time, resources, and they're being pulled from things that they're doing. So definitely no mandates at this time unless we got a maybe a fairy godmother in Dr. Monroe, that the CDC Foundation is going to give us a lot of money to do that. Okay, but unless we can get that kind of assurances from her, I think we need to kind of.
There's a lot more federal money coming.
Well, that's fine. Then you can make the recommendations on the money comes in. Okay. And then my last point, and I don't know how to figure this out in the governance, but I think it's critical from a public health preparedness standpoint, how we're able to have public health talk better with our clinical care systems, that there's better integration between the two. And I think the Department of Health has the ability to do that based on how they design their districts of public health preparedness, increasing that communications and that integrations from a public health preparedness. And so that's the only piece I saw here that is not articulated, and it really could be done internally. That doesn't have to be articulated here, but just make my last comment. Thank you, sorry.
Thank you.
I'm sorry, I have to say one thing.
Yeah, please. You always get the last word.
Shane's giving me the evil eye, so that will come in emergency preparedness. And because of the way our clinical healthcare systems functioned regionally with us, we may redraw those emergency preparedness lines because it really fell naturally with certain referrals and hospital systems. So we're in the process, and our team has already kind of grown up.
Well, I also want you to think about when you've got a very large metropolitan city that has been doing public health preparedness.
You know, we've always had two laws in Indiana. One for Indianapolis and one for the other 91. So you don't need to worry about it.
Lake County would like to enter that conversation.
Thank you. Thank you.
The question is coming up on draft recommendation number 7 as to whether we should push this far on this hard or not, or whether we should not. Let's hold that question, and next month, let's be prepared possibly to take a little vote on that. And would that cover that?
I'm just uncomfortable with where we are. I
Right.
can go either way. But
Right, that's fine. So let's kind of think about, we're going to have that on the agenda for a specific vote and discussion next month.
Thank you.
All right.
Could we reframe the question though? Because the issue is really about the responsibilities for medical oversight. That's one issue. And the other issue is the responsibility to lead the health department. I think they're very distinctly different issues. I mean, if you keep it as framed as it is now, the expansion of adding advanced practice nurses and PAs, frankly, I don't think I would be supportive of it.
Okay, well, why don't you do a revised piece of language, which might be a substitute amendment that we might vote on. How's that sound?
Yes. Yes, Senator, that is fine.
Okay. All right. Let's give Lindsay Weaver her chance here. We're taking her time. from
No,
her.
that's okay. And my presentation is shorter. So good afternoon, everybody. I'm really happy to be here. Just really quick to go back to the conversation around internships and opportunities for exposure. I will just say, when I was doing my residency in emergency medicine here in Indiana, I did a month rotation with Senator Pat Miller, which was my first big exposure to state government. And then I'd actually like to say that I have one of my emergency medicine pediatric residents here, Dr. Patel, who is doing a rotation in public health this month. So she is definitely a future public health workforce for sure. So I think that is a lot of opportunity. Okay, I think I have the slides here, right? Yep. All right. So public health data and systems are historically siloed by disease condition, funding sources, reporting requirements, and other factors. So the current antiquated data systems do not allow for an overarching strategic plan to improve the health of Hoosiers. The Indiana Health Information Exchange provides one of the largest and best clinical data repositories in the country, but we are not fully leveraging it to support our public health initiatives. The current structure does not maximize federal dollars available for healthcare quality improvement initiatives or coordinate projects across state agencies. Local health departments have a wide variation in analytical and system sophistication, which I discussed pretty significantly last time I talked to all of you. And this results in an inequality between counties of disease surveillance and environmental regulatory functions. So our overall goals are to ensure the coordination of data across health and human service entities at the state level, to maintain privacy protections and appropriate consents for use of data, to promote integration of public health data for clinical use by providers to optimize our health outcomes, provide tools to assist local public health officials to make data-informed decisions, and modernize public health systems and processes to increase efficiency and enhance service delivery to Hoosiers. So our recommendations are to establish a state public health data system advisory committee, to formalize and strengthen the state's relationship with the health information exchange partner to promote improved clinical outcomes and outbreak management, to enhance data analytic tools and resources for local public health, and to maintain state-led digital transformation efforts to modernize public health systems and paper-based processes. So draft recommendation number 1, establish a state public health data system advisory committee. And possible action items. A, develop data governance across entities with appropriate privacy protections and security provisions. So at the direction of the governor, the HHA's agencies, this is for example, DOH and FSSA could establish this committee, this public state advisory committee, that would be charged with informing agencies on the enhancement of public health data in Indiana so that it directly benefits the people of Indiana. The committee members would be determined by those agencies and reflect current needs. So an example of that is we heard that maybe before the pandemic, it might not have been recognized that a behavioral health specialist might benefit on that committee. So depending on what's going on in the community, you can pull other people to, maybe it would be an opioid specialist for another example. That public health system data advisory committee's duties could include developing a strategic plan for public health data initiatives as outlined in B there, supporting interagency coordination on public health data, considering data governance across all entities engaged in public health data, including data security, which we know is definitely something we need to continue to look at across the state, and engaging with legal consult, establishing relevant work groups to inform efforts around public health data enhancement. Draft recommendation number 2, formalize and strengthen the state's relationship with the health information exchange partner to promote improved clinical outcomes and outbreak management. So possible action items. Codify the relationship and leverage funding opportunities, both federal and nonprofit, to enhance services and promote sustainability. So we could do this through a formal recognition of IHI and state code. It would facilitate distribution of funding for key data initiatives supported by the HI and the ability to capture federal dollars. In coordination with the Public Health Data Advisory Committee that I mentioned in recommendation number 1, they could establish a formal state relationship that improves data governance, public health surveillance, and healthcare quality. B, increased number of providers connected to the health information exchange. The health information exchange data and functionality are limited by the number of providers that are currently contributing and accessing the data. Gaps exist in connection between skilled nursing facilities, independent practices, home and community-based providers, among others. So we could establish a formal cross-agency policies to increase those providers that are connected to the health information exchange. So an example would be FSSA could add the requirement for managed care plans to have their contracted providers connect to the health information exchange, which we have seen in other states. We could also develop incentive programs with captured federal funds to support these policies, and increasing the number of providers connected has the added benefit of reducing healthcare costs by addressing inefficiencies, redundancy in data capture and storage, medical errors, inappropriate care, and incomplete information. C, establish dedicated public health focus with the health information partner. So we can maximize the utility of the health information exchange for the purpose of enhancing public health in Indiana and elevate the priority of public health data needs. Establish a formal public health work stream to standardize data reporting for public health, such as race and ethnicity, linking home health data for pregnant women, addressing maternal and infant mortality by really leveraging the data that we have available. And also enhancing public health services such as a functionality for the Department of Health to directly communicate with clinicians could work through that formality and that increased access, and also to evaluate the social vulnerability index and closed loop on social determinants of health referrals. Draft recommendation 3, enhance data analytics tools and resources for local public health. So A, establish district level data services. There's district level again, to support local health departments and cross-county analysis. So this would ensure a standard level of analytical capacity is provided statewide. The Indiana Department of Health could establish district level services, like I said, to support what they're doing there. That could include the ability to do analysis, surveillance, support low resource local health departments in completing that analysis, to develop dashboards and identifying emerging trends. And we can also provide financial support to implement that, or we would need to supply financial support to implement that. And B, establish baseline technology, security, and resource requirements for local health departments with financial and logistical support for those to achieve that compliance. So the local health departments, as we know, have varying levels of data technology sophistication and varying personnel resources dedicated to reviewing that data. So this would establish a requirement via potentially code that local health departments meet baseline requirements so that we can increase the level of that ability at every local health department. And then, of course, we would provide the opportunity for local health departments to use state systems in place of meeting these baselines. C, local health departments promote digitization of inspection and permit records to improve access to key public health data. So there could be established a standard of collection and reporting of all data collected by the local health departments that support the modernization of systems used to collect the data to allow for an interconnected data view that would decrease the redundancy and identify inconsistencies, for example, maybe across state lines. Also from the state level, the Department of Health could enhance those data systems and the reporting to provide more timely access to it and public facing information for those things that should be available to the public. And lastly, draft recommendation 4, maintain state-led digital transformation efforts to modernize public health systems and a paper-based process. So charge the Department of Health with an evaluation of our resource structure and allocation between state budget and grant funded positions, supporting the digital transformation, and then dedicate funding to state resources versus grant funded positions to support the long-term sustainability of what we're currently starting with our digital transformation, but right now is relying on COVID federal funds. This will make a difference for us as a state agency and for a state so that we can have a long-term sustainable solution to data here in Indiana. I will remain available for questions, but I will let you guys proceed. Thank you.
You do very well under pressure, Lindsay.
She's in emergency medicine.
Dr. Kane.
Yes, so let me just compliment you, but I'm concerned about your draft recommendation number 4, where you say dedicate funding to sustain the Indiana Department Office of Data and Analytics. I think you got to get a different terminology than sustain. Because if you're really going to be supportive of the efforts that we're going to need the data and analytics for all of our local health departments that don't have that ability. Sustain tells me that you're going to continue your funding at your same level. And that's just unacceptable to me. You got to figure out how it needs to be increased or something in order to accommodate all the needs that we have from all these local health departments. So that's the first major point. Who's ever good with wordsmithing? But I think all these others are just fantastic recommendations and definitely needed if we're going to improve our clinical outcomes. This is excellent.
Mindy?
these are a lot less controversial. So it's gonna be easier. I supportive of all these things. My only suggestion, and it's been more of a question because maybe it's inferred and I didn't catch that, but on the draft recommendation of 1A for the development, I think of that advisory committee. Can there be at least a slight bit of local representation? Because there's always a little bit of a gap between what we do need and what's developed at the state level and shared. A good example is like the sort of services database. Some of these databases, we don't get to help craft what it is we need. So we get given what we're given and it's not what we need. So I wonder if we're developing this, if there's at least slight representation or even just advice, maybe, or a
You can say
liaison.
you can say with local representation.
Yeah, is that maybe already
involved
planned?
with local
Okay,
representation. involved.
perfect. I think that'll help bridge the gap that currently exists now.
Good, thank you. Yes, Karen.
I wonder if my thoughts are inferred as well, and I just didn't read into it, but, and I've asked this question to you before. When we talk about the data analysis, does that also include recommendations for how to use, what to do in response to the data? Because I think maybe that's inferred in recommendation number 3, or maybe that's in the workforce part.
Right, yeah, so there's 3 components to it, right? It's the people who know how to receive the data, make sure all the connections, that really that technology piece, and then there's data analysis. How do I use that data that I'm receiving to actually build the story? So that person could be that person, but then it's kind of that next level. How do we communicate it out, right? How do you get that information out to the public? So it really is this several pronged, and honestly, that is where you would engage like your physician leadership, that can kind of help with that storytelling, or what does it say? But the data analysis is really that person who takes the data and figures out what does it mean.
And helping maybe connect the programming that could address that particular data.
Oh, right.
Good point.
Mayor Bob and then Commissioner Dawes.
Dr. Weaver, thank you for this. And along the same lines of Dr. Veal, that the data is so critical for everything that we do. And it's going to be even more critical in the future as we ask for funding, right? Because you've got to prove that the data is generating the results that our legislature and our communities want. How do we inject the training that's necessary on how to use the data? And I'll use this as an example. During COVID, in our community, there was a huge data void at the local level, not state level. You guys were fantastic, and we ended up having to come to the state to get better information so that we could implement strategies at the local level. So how do we train our local health departments on the use of the data? And how do we incorporate that in here as a primary objective and recommendation too?
Yeah, that's a really great point. And I think honestly, it does take a specific skill set, right? I think that what our job is to be able to pull that data and then put it in a form that is usable on the local level, because we are all getting that. And that is where the idea of having these, again, kind of district or regional support teams that could be working more directly with that local level on what they need. So if they, for example, I don't know if it's avian flu, or if it's a syphilis outbreak or whatever it is, that's, it's more kind of directed and local, that they have that support team to help them work with the data that could also do the translation of this is what the data means. And here's potentially, they would take it and be able to use it. Is that answering your question?
Yeah, and it is. So how will that infrastructure work? I mean, will there be a specific data officer, for example, at the regional level that's interacting with the state, that's not only just compiling information and providing it to you, but understanding how to interpret it?
So I think honestly, it would be ideally this person would be, this team would be integrated with that district level support team. So if there's a district leader, the other resources that Pam was talking about as well, an epidemiologist, that all those people are working together to be able to provide that support on a local level. They're all helping with tell that story.
This is so new. We didn't have a data officer or a data and analytics department until the COVID pandemic. So it really is, it is a new thing, but it needs to be a data analyst and an epidemiologist at a regional or district level that can interact with, say, our hospital system, epidemiologists and data analytics people, because it's really them working together, I think, that helps to paint the picture for the whole community.
So
And that data is so important to create information from that then we can
Yes.
make decisions off of. And that's the translation part that seems to allow us to fumble the balls, so to speak.
Yeah, and it helps you focus resources, right? If you have the data, say, this is the group of people we need to be communicating with, concentrating on, reaching out to, then you have to have the data to support it, to direct you to that place.
But the epidemiologist is going to interpret it for you. They're going to say, hey, based on this data here, this is what I think is going to happen to your community in the next 7 days. I think your cases are going to increase by this amount, so you need to be prepared for a decision you may want to make. So the epidemiologist helps to do the data interpretation. The data person is making sure that you're getting the data from all the different locations and resources in order for you to make informed decisions. And then some of those results you get may generate some more questions. And so that team's ability is to go further and get the additional information that you may need. There may be something happening with your school system or school outbreak that you wouldn't have known otherwise without that data team telling you about it, but they can give you recommendations. And the state will be really good about having epidemiologists that can tell you, this is what I think is happening. It was so our epidemiologist is so beneficial related to that, but I also have a separate data people telling me, I need to know how many cases I'm seeing in kids from 0 to 17. If I'm having a problem and I didn't even know about it, but my data is saying you got a problem. So you got to do something about this.
I think Dr. Box knows me well enough now, but the lack of really good data during the pandemic made decision-making very difficult.
Oh, yeah.
And then because decision-making was so difficult, that created unnecessary conflict on how we should proceed and the decisions that did get made. And I want to compliment you all again, because you all shared a lot of data with our community that did help us make better decisions. And so I'm glad to see that this is a priority.
And we did share it with every county across the state, but honestly, many counties came back and said, we don't understand what this data is telling us. And we just didn't have enough.
You got to have the
analytics people to
interpretation.
do that.
Sure.
Kara and then Hannah.
I just, personal opinion, I think this is one reason I love the idea of the district level support is because, to use your example of avian flu, they cross county lines all the time. And they're not siloed to a county.
Yeah.
I had to stand on the highways trying to keep people from my county. It's cold out there.
Right? To pre-pandemic, we didn't have really any collaboration from county officer, maybe a little bit, but I think this is just solidifies the need for that district level support.
Hannah?
I think, so this is fabulous. This is very exciting to talk about having more robust data structures and governance for decision-making. It's also highlighting how it's going to be really important to identify the skills that are needed and create a plan for the workforce based on, okay, this is the direction we're moving forward with our infrastructure, or we're staying status quo and we're just going to identify what everybody needs. I'm just saying, I don't want to make any judgments. That has to happen. And there have to be the epidemiologists that are subject matter experts to interpret, the data analysts that know how to manage, clean, code, prepare the data in a way that it can be confidently reported. And so that there is going to be a need for, once we know how we're going to structure or what our structure is, then it's what skills do we need and what types of people with training do we need to fit into those. And that's why a workforce plan will be important.
But the beauty about this is you can get data more than just COVID.
Yeah.
You may want to know, oh, wow, what's my infant maternal mortality? Or, I might want to know what's happening with diabetes, or, it's the subject of your interest, whatever you're interested in, they can produce today.
Commissioner Dawes,
Matt?
and then Dr. Wilson.
Yeah, thanks. My brief comment, initially I was thinking that draft recommendation 2 and 4 maybe went together or could be combined, but after the discussion, I think they are separate. And then somewhere along the way, we taught for a health information exchange, and then Dr. Weaver, it could have come from your earlier presentation to us, but Indiana has I think, a good, strong health information
I think we're
exchange
the we're number
organization.
one in the
that
country if we're not in the top 5.
Why don't we go ahead and state that in our document? So I don't know if that would be appropriate, but
Yeah, I think so.
anyway, that's what I was
I
thinking.
can see us
Good
developing
point.
another one, but it was,
Build on that
suggested that it
strength.
should not be assumed that they would be the health information system. to me.
I see.
So that's why
Okay.
we were more vague.
Okay, but I mean, and
I
that
think
comes,
Oh, I see.
technically
Okay, I
that has
got
to
you.
happen.
Okay, I got you.
okay, and that purely comes from my healthcare background through the
Yes.
hospital and knowing of that organization and so on. So, thank you.
Dr. Welsh.
Thank you, thank you, thank you. It may be the shortest presentation, but I think it's one of the most important. So information is the difference between success and failure. I particularly like the Establishment Advisory Committee. I think that will help with the safeguards that you mentioned, Advisory Committee. I think that will help sell this more effectively to the public who have questions about it. I think when there'll be some educating that'd be necessary, probably not speaking out of turn, that I'm sure that the State Medical Association would be willing to step up, and they're always doing educational programs that works with the State Department of Health. I think one of the key things may be to advise, give advice to local health departments as they need to upgrade or purchase new IT equipment. What sorts of equipment will be compatible to the future when this goes through? I like the dedicated funding. I think that will help a lot. One of the questions may be, and we dealt with the trauma care system, is when the information goes across state lines, how to get that so we can look at it. There was an incident a number of years ago in one location where there was a spike of cancer cases, but it was not brought to the attention of Indiana because they were going to Ohio to get treatment. So that information was going to Columbus, not to Indianapolis. As you know, since you chair the Trauma Care Committee, as we look at data from trauma cases, it's sometimes difficult to assess, how to address that data, because those people end up getting treated at Louisville or Cincinnati or Chicago.
Gary, let's go over to Chicago.
Yes. Kim.
Just I think building on that very quickly, what comes to mind for me is implementation also, and for the local health departments. So what do the local health departments need in order to engage in this? And how do we make sure that we are providing that as part of these recommendations, or in parallel?
It's in 3B.
It is.
I
there.
looked at it. It's in 3B in the recommendation that they're going to provide with financial and logistical support for their whatever this baseline technology.
Okay, I think there's more. I think there's more to it than that. Is I guess all the capacity piece and the.
Well, they'll have to do an assessment, clearly.
Yes, Dr. Howerson.
Thank you, Mr. Chairman. So Lindsay, great idea. I love this. It's good proposal. I think there's really a lot of great stuff in here. Again, the devil's in the details, right? So we look forward to working with you on that. I wanted to pass on congratulations from many may not know. We have some of the country's best public health informatics people in our school and in the School of Medicine. And so collectively, they really enjoy working with you and with the staff at the health department. And so they're excited. I had a chance to share this with them, and they're very excited about the whole direction that this is going. Just two quick questions. One is related to sort of an age-old question, but it's really important, I think, for a lot of the local health departments in particular, and that is, could you assure data reciprocity? In other words, if health departments put the data in, can you guarantee they're going to be able to get it out?
Yep.
Because there's a lot of systems that say, well, yeah, you have to take it in, but we can't give it back to you. So and
That's
that
what we
becomes
have now.
very problematic. So you're okay with that?
Absolutely.
All right, okay.
If they don't have that data, they can't respond to their community's
Right,
needs.
exactly. And
100% on board
that's
with
the
that.
argument, yeah. And then the second thing is, I think over the years, and Dr. Monroe may have a different viewpoint, but I think at CDC in particular, there's probably been hundreds of millions of dollars, maybe billions of dollars that have been spent on IT-related things in public health, most of which have really never reached their intended promise, in large part because everybody did it a different way. And there was always some other vendor that had the greatest idea. And it's that independent, in some ways it's great because of creativity, but tell me that I think I know the answer, which is, I think it's really important to be assured that Indiana will be working with other states and CDC closely to assure that what we come up with is not an Indiana only answer, but that actually will be interoperative and that will work with other states and will take advantage of the knowledge that everybody's gaining as it relates to this, because this is a huge amount of money that will be spent, and it'll be probably the greatest investment we make because for all the reasons that we've been talking about. But there's also a good likelihood that it won't work at all. So,
that's a good point, but unless you're the emperor of the United States, you're not going to be able to guarantee that. I've been through that with so many other types
I
of
know.
systems.
all I'm saying is.
It's a good warning.
Wouldn't it be great though, if we could be
Yeah.
assured that we're going to be working with others to try to get the best?
Well, you won't be assured. I think what you can put in the report out of what you're saying is keep that thought in mind as you develop a system.
It's going
That's
to be
the
difficult to be emperor of the state, to be honest with you.
I agree.
Because, no,
agree. Yeah.
I really want to be frank about this. Our local public health people are frequently connected to the local county commissioners and all the other networking. And so when the security is not good at the county level, when the information systems at the county level aren't to the level where we can even connect to them, it makes the whole process very difficult. And so I think there needs to be a whole state solution for some of this that goes even beyond maybe local health. And I think IoT is kind of thinking along those lines and working that process.
Comment. One thing though that is very intriguing to me, and I'll share with you, I talked with folks out of FinTech. So the financial technology, right? They told me that had the pandemic occurred 10 years ago, the financial systems would have folded. They would not have had the technology and the security. And so same thing is happening with public health. We've got these advancements taking place in our technology and our capabilities. You've got the cloud, you've got, with what's happening with data modernization, so forth. So I think we're in a really different place in terms of our potential capability that, maybe the emperor may not be needed as much because I think technology is
I
going
think it's a big world.
Yeah.
Do you need to put anything in here in terms of the security, cryo security kind of stuff? Is such in
That's a
recommendations?
good point. I mean, that is huge.
Is something, because we had a huge attack and we were out for a couple of months. We couldn't even use email. So I something, so funding related to make sure that.
Actually, that's a really good point because that's.
Yes, I thought it was in one of our recommendations, but it might have been just in my notes. But yes, security is a huge
May wanna put
component
that
of
in
that.
So you can get
Is it
additional
1A?
funding
Okay.
for that.
Yes, here it is.
Okay.
Develop data
Is it there?
governance, appropriate privacy protections and security provisions. Yeah.
Privacy protection.
We can expand on it.
Okay, that's it. You
Yeah.
got it.
Yep.
1A.
Cybersecurity.
And just a comment, I will say that the CDC Foundation is doing a data modernization whole thing right now. So we are engaged in that and have been paying attention to it. And we spoke to 3 or 4 different health information exchanges from across the country and states about what they're doing to help engage just for these presentations.
Yeah, that's great. Great.
Well, I hope that this process has suited your desires in terms of how we're developing a report. And I do think we need to take a minute to thank the three presenters and the people from the Department of Health.
This was outstanding.
This
Oh
is
my
taken,
goodness.
you can't imagine what a tremendous effort it's taken for them to be prepared for this. And so next month, we will deal with the other three work streams, and Dr. Monroe will chair the meeting, and we will be meeting May the 19th, Thursday, 1 to 4 again. And then one further reminder, our June meeting has been changed to the 30th of June. So Dr. Box or Shane, is there anything else we need to say before we adjourn here today?
Think about your vote on the one thing that we're going to vote on.
Yeah, that's right. We do have a voting issue, right?
But I really
You gotta
appreciate
vote
it. It's clear to me people had read these beforehand. Really appreciate the time you invested in it.
And thanks for developing the draft to start with, because it would have been enormous to work with a blank slate. So thank you.
Teamwork. Worked
Helpful.
really hard on that.
Senator, I just want to say thank you to Shane too, because not only did we get all this great information, but there was a lot of personal, contact by Shane and his staff about, talking through this.
Yep.
So thank you, Shane. Appreciate it.
They have worked hard.
And Kathy, you get credit back there. HMA has done a great job organizing everybody's recommendations.
Thank you all for being here.